Hi guys, welcome back. The next topic we're starting is systemic lupus erythematosus. And before we discuss the specifics of the disease, I would like to talk about a few miscellaneous facts. One, you can see image here of a Twitter handle of Selena Gomez. Yes, the famous American pop singer Selena Gomez, who recently became famous because of her hit single "Calm Down." And prior to that, she was in news in 2017 and 18 because this famous American pop singer went undiagnosed with SLE and unfortunately developed lupus nephritis, for which she had to undergo a kidney transplantation. Luckily, her friend, a childhood friend, agreed to be a donor, and since she was in a advanced country, money was not a problem. So she underwent a kidney transplantation and recovered and posted about her experiences on her Twitter handle. And you can see the image of both childhood friends smiling away, the donor as well as the recipient. And post this, Selena Gomez was made the president of the Lupus Foundation to increase the awareness or presence of systemic lupus erythematosus, especially in women of childbearing age group. Now, do you know that this disease is an autoimmune disorder? It's an example of type 3 hypersensitivity. I'll jot that down in a while, but you can notice a very characteristic rash which is present in this condition, which is also referred to as a butterfly rash. So you'll notice this over the bridge of the nose as well as over the cheeks of this patient, and therefore it gives that very classical butterfly distribution. Now, why I'm mentioning this right in the beginning, because I'm not started with clinical features, is because of the fact that in one of the recent exams, he just tried to play a trick on our mind. So I'm just sensitizing you to the same at the moment. The question said that which of the following is not a feature of systemic lupus erythematosus? And the feature that was given and was the answer to the MCQ was the word malar flush. So what is seen is a malar rash. This malar rash would be present on the bridge of the nose, over the cheeks. It can be over the ears as well. It could be on the extensor aspects of the arm, the V of the neck, and on the back. So on the sun exposed parts, and usually this rash would tend to worsen on sunlight exposure. But in the exam, he deliberately put up a statement malar flush, which is obviously not a feature that is encountered in SLE, whereas you see malar flush is what you read with respect to a valvular heart disease. I mean, this is a feature of low cardiac output, the facial appearance in patients of the commonest valvular lesion in India due to rheumatic heart disease, that's mitral stenosis, whereas in SLE we would be having malar rash. Now, SLE per se is a condition where the immune system is turning against itself. It's an example of type 3 hypersensitivity where we have immune complex mediated damage and the complement system starts attacking self. Along with this, from the pathology domain, he can also ask you regarding the phenomenon of increased autophagy. And along with this, there would also be netosis. Now, as you're aware, netosis became very famous with respect to COVID. Netosis, net basically means neutrophil extracellular trap, and this is a novel, I can say, host defense mechanism. So, to draw parallels and explain netosis or the process of neutrophil extracellular traps, I can say just like Spider-Man, right? Spider-Man, whenever he sees the bad guys, he'll just throw a web. As children, we used to watch the Spider-Man movies, and he used to do this hand thing, and then suddenly there was used to be a spurting out of a web which used to trap the bad guys. Similarly, what the neutrophil here is doing is it's trapping and killing the pathogens. But here what is happening is that the same process which is designed actually to pick up the bad guys and helping trapping and killing the pathogens might be attacking the self red blood cells as well. And in case this net is going to trap the RBCs, then autoimmune hemolytic anemia will develop. In fact, hemolytic anemia is one of the diagnostic features for this particular condition that results in normocytic normochromic anemia. In fact, there are two reasons why you get normocytic normochromic anemia in SLE. One is obviously because it's a chronic disorder, but over and above this, because there's an autoimmune process also occurring, and that's there are two reasons why this is happening. One is the complement mediated damage, and second would be these netosis process, which is accelerated and tends to attack self antigen. So it's like the immune system is attacking everything of its own. It will attack sweat glands. I mean, imagine an autoimmune disorder that attacks your own sweat glands, sebaceous glands. So adnexa are destroyed. The immune system attracts lymphocytes. So you get a lymphopenia, platelets are hampered. So thrombocytopenia, not only skin manifestations, kidney manifestations, but multiple host of manifestations would be described for this. And subsequently, I'll be describing the SLICC and the EULAR and the ACR, American College of Rheumatology criteria, the latest ones for diagnosis of this condition. As far as the gender part is concerned, you're aware that females are the ones which are more affected. In the older edition of the textbook, he used to mention a ratio of 9:1, and that was static from days like I was studying, I mean 20 years ago. But now he's mentioning a gender ratio of 5.5 to 6.5 is to 1. So just a slight, I would say, a change in the statistics as compared to the older data. And this also tells us that there has to be something related to the genes on the, I mean, why is it occurring per se? So this has been shown to be not because of estrogen. It's rather because of a particular set of genes which are present on the X chromosome. And one of the genes which is incriminated contributing to this, you don't need to remember the name, but I'm just saying it for the sake of completion, that would be TREX1 gene, which is responsible for pathogenesis of SLE. Now, more is these copies of these genes on the X chromosome, more will be the severity of the disease. And what they found out is that Klinefelter syndrome, you're all aware that Klinefelter syndrome per se would be a male patient, but still we read that the incidence of SLE in these patients is more. You see, traditionally we read about SLE in women. Like I began by saying it's a disease of childbearing women, and that is why Selena Gomez was made the president of the Lupus Foundation to increase the awareness of the disease. But then Klinefelter syndrome, as we are aware, is a male who's 47XXY, but you can see that the extra set of chromosomes which are present here, and that would mean that there would be more copies of the genes present, and that would mean that the incidence or severity of SLE in these patients, the incidence is also more, as well as the severity of SLE, both is on the higher side with respect to Klinefelter syndrome. That is just to sensitize you to the fact that it is not estrogen, but it is the number of X chromosomes that would be deciding the severity of SLE. And as far as the systems are involved, in fact, whole of the body is involved, but then the questions can be asking you regarding what is overall the most common body system involved in SLE. Then do not answer photosensitivity, do not answer skin involvement. Yes, skin involvement is important. Constitutional symptoms are important, but overall the most common body system involved would be answered as musculoskeletal system. And a large number of these patients would be presenting initially with low-grade fever, constitutional symptoms, malaise, fatigue, night sweats, and along with that there would be development of myalgia as well as joint pain. And because of this musculoskeletal involvement in the joint pain, which can even involve the small joints of the hand, initially you might think that you are dealing with a case of rheumatoid arthritis, but then rheumatoid arthritis subsequently will always cause erosive arthritis, whereas majority of cases of SLE, you will notice that this would majority of cases be a non-erosive arthritis. In fact, the chances of erosive arthritis would be close to about 10%. And then the joints which are involved with respect to SLE would not only be the small joints of the hand, but even large joints like the knee joint can be involved as well. So unlike in rheumatoid arthritis, where you get the classical morning stiffness, you get presence of rheumatoid factor, then you get anti-CCP, cyclic citrulline peptide antibody, which is one of the both sensitive as well as specific tests. So I've discussed rheumatoid arthritis separately, where you will hear me talking about PIP, MCP wrist joint involved bilaterally with morning stiffness, with RA factor, with presence of anti-CCP antibody, which would not be present here. And moreover, with respect to this condition, you would be having non-erosive arthritis, and then even large joints like knee joint can be involved as well. Then according to the latest criteria, that's the 2019 ACR criteria, what he has done is that for each system involvement, he has allocated some points or weightage. I mean, what he's trying to do here is that based on common systems, because we need to pick up the involvement of common systems. So that is why he has given a mathematical value, and I'll show you the table subsequently. But at the moment, I would just like to handle a question of the previous years where he said that according to the latest ACR diagnostic criteria, which manifestation of systemic lupus erythematosus would be assigned maximum points or maximum weightage for diagnosis. So your answer would be given as renal involvement and renal biopsy findings, in fact. And well, the renal biopsy findings, one you read in pathology is wire loop lesions. So I'll speak about that wire loop lesion subsequently as well. But at the moment, what he wants to hear is that renal biopsy and the couple of classes of involvement, the total of 6 classes of involvement with respect to lupus nephritis, out of which it is class 3 and class 4, which are ones which are usually the common ones that are identified. So renal biopsy findings of class 3 and class 4 LN. LN would basically mean lupus nephritis, are given a maximum value for diagnosis of this condition. From the treatment perspective also, what you need to remember is that in lupus nephritis, if it's going to be stage 3, 4, 5, we are going to aggressively treat the patient. The drugs that we'll be using for treatment would be mycophenolate, and along with that calcineurin inhibitors like tacrolimus. So I'm going to jot it down in the later part of the disease in the treatment, but I'm just sensitizing you to the fact that lupus nephritis is one of the big time killers here. You see, there will be a slight controversy because some platforms would be mentioning regarding accelerated atherosclerosis as a leading cause of death in these patients. Well, kidney involvement also causes accelerated atherosclerosis, but as far as Harrison is concerned, he is mentioned, and you can go to Harrison as well, and I'll subsequently mention the page number as well. He has categorically mentioned that usually in the first decade of life, these are the words of Harrison, in the first decades of life, the usual cause of death with patients of SLE would mainly be renal involvement and infections. And why infections? Because the immune system will be attacking self also, so there would be lymphopenia. Plus, you're going to give steroids. Steroids are going to again decrease the immunity of a patient. So a combination of your treatment modality as well as the disease attacking self lymphocytes, there can be infections, and over and above this lupus involvement. And I mean, why that renal biopsy is incorporated as is having maximum weightage for diagnosis of SLE is that lupus nephritis alone, if it is present, I'll talk about multiple manifestations, and you read about that. They in pathology also. I mean, joints are involved, hemat is involved, heart is involved. You read about Liebman-Sachs endocarditis, so many manifestations. But one single manifestation that is having maximum weightage, that this alone is sufficient for diagnosis of systemic lupus erythematosus, is class 3 and class 4 lupus nephritis findings. That would be diffuse lupus nephritis. We'll talk about the histopathological variants as well, but at the moment, the main point is that renal involvement is given maximum weightage. And then he can also ask you about the latest criteria from the perspective of the word obligatory entry level criteria. What I mean by entry level criteria is that without this involvement, you cannot say SLE, and that would be presence of anti-nuclear antibody. Well, anti-nuclear antibody in titers of more than 1/80 is the most sensitive test for diagnosis of this condition. It's the screening test for diagnosis of this condition. So unless and until anti-nuclear antibody is positive, we cannot make a diagnosis of this condition. Having said that, I would like to tell you that this antibody can be present in the body of these patients for as long as 3 years before clinical manifestations will occur. So lots of time we might be picking up, in India nowadays, the tendency for coming up for annual medical checkups is increasing, especially post COVID. People have become more health conscious, and you will notice people signing up for medical insurance, comprehensive medical insurance for family, where it would be mandatory to go in for an annual medical checkup. So anti-nuclear antibody can be picked up as early as 3 years before the disease manifestations can occur. So that's the importance of annual medical checkup. You can see, especially from the perspective of a woman in a reproductive age group. And in this criteria, the diagnostic criteria, this is spread over 7 clinical domains. The clinical domains will be discussed subsequently, but they are the standard ones. I mean, hemat involvement causing autoimmune hemolytic anemia, lymphopenia, then musculoskeletal involvement, cardiac involvement like pericarditis or Liebman-Sachs, lung involvement like pleuritis or pericardial effusion or shrinking lung syndrome. So the 7 clinical domains, entire classification and the diagnostic criteria spread out. And then we have immunological criteria also. Those immunological criteria would be, anti-Smith antibody, lupus anticoagulant antibody. I mean, anti-nuclear antibody is anyway entry-level criteria, but there are other antibodies also, like double-stranded DNA or anti-Smith antibody, which is one of the most specific ones. So there are 3 immunological domains present, and the total points which are to be gathered by the patient before we say that it is a diagnosis of SLE would be total of 10 points. So you need to remember this data that I have currently said here before you, and it will become easier as you progress onto the subsequent slides. The learning point for you at the moment is 1. Malar rash is a feature, not malar flush. तो क्वेश्चन थोड़ा देख लेना ध्यान से, malar flush जल्दबाजी में गलत हो जाता है. The commonest manifestation is not dermatological, it is musculoskeletal involvement. The feature which is a defining manifestation of the disease, I mean, this alone is sufficient to say that, okay, we are dealing with anti-nuclear antibodies, obviously to be documented. I mean, not without it, but then one feature along with anti-nuclear antibody, which will say that, okay, we are dealing with lupus, is renal biopsy finding of class 3 or class 4 lupus nephritis. And then the latest criteria will be discussed in detail, where at least number 10 is to be remembered. That is a final score of 10. Just like we have curve 65 score, no? Similarly, here we have designed a score, and on basis of that, so like in pneumonia, we have curve 65. like we have various scores, like you have Q SOFA score to be studied in surgery, you read curve 65 pneumonia, always asked in the exam in respiratory system. Similarly here there would be a 10 point value to be attained, critical value of 10 to be obtained before you diagnose the patient as systemic lupus erythematosus. And next I'll focus on SLICC criteria for diagnosis of this condition. Now the mnemonic that I'll be teaching you to help and remember SLICC criteria would be SONAR, and alphabet S would be here used a couple of times. So let's just practice it here. The first time you are going to remember that is for the musculoskeletal involvement, that would be synovitis. So the disease does not start off as a frank arthritis, it is usually a synovitis, and that is why I was saying majority of cases are going to be non-erosive and the chances of erosive arthritis would be close to 10%, and this should be involving at least a minimum of 2 joints. In majority of cases, they can be constitutional symptoms as well in the form of low-grade fever, cachexia, weight loss, even frank depression could be present, evening rise of temperature can be present. And then you will notice that this lady is telling you that apart from this fever and weight loss, she is also noticing that there is swelling in her hands. There would be soft tissue swelling and there is tenderness over the small joints of the hand. And because of this tenderness, which she is pointing over the small joints, both in clinical practice as well as in multiple choice questions, there is a probability that you might start thinking that the question is trying to talk about rheumatoid arthritis, but then rheumatoid arthritis will have additional features also described, like morning stiffness, which I have not described for this particular condition at the moment, and then subsequent workup will in this particular case will not have RA factor or will not have CCP antibodies, which are must for diagnosis of rheumatoid arthritis. I would like you to listen to rheumatoid arthritis subsequently, where I've described JSAD. JSAD would mean joint involvement, serology, antibody profile, and the duration manifestations. So JSAD is a mnemonic again that I have created actually to help you remember. I mean, joint involvement is making the patient sad. So JSAD, J for Jack, JSAD is a mnemonic that we use to remember features of rheumatoid arthritis. And SONAR is a feature that, or a mnemonic that we use to remember features of systemic lupus erythematosus. Then even large joints can be involved in this particular case, which is little unlikely with respect to rheumatoid arthritis. I mean, monoarticular rheumatoid arthritis maybe yes, but otherwise per se having knee joint involvement with respect to rheumatoid arthritis would little be unlikely and is relatively more a possibility with respect to SLE. So there would be a non-erosive in majority of cases, a synovitis or a intermittent polyarthritis as the textbook is describing it. And then there would be another feature that again begins with S, and that would be serositis. And here, if you're making notes, I personally recommend handmade notes by yourself, because especially with rheumat, because there's so much of data, it's all about remembering. So it's always a good idea to practice it with handmade notes so that you can remember it. Otherwise, if passively listening to this data would not make too much of sense. So here I would suggest you to make a 2x2 table with respect to the questions will say that what is the most common lung involvement seen in patients of SLE and what is the most common heart involvement with respect to SLE. And then the question will also say least common lung involvement and the least common cardiac involvement per se. The lung involvement is commonest one is easy to pick up, that would be pleuritis, that will cause a pleural rub, and the cardiac involvement that is commonly seen would be pericarditis, and therefore pericardial friction rub with ECG changes of ST segment elevation with a concavity would be on. The least common lung manifestation would be primarily because there would be lung infiltrates and therefore there would be lung fibrosis as well. So a very classical term that I'm writing at the moment before you, that would be called as shrinking lung syndrome. I mean, this is an important terminology that you guys have to remember. This is itself a one-liner question of NEET as well as FMG exam. Shrinking lung syndrome is the least common lung manifestation with respect to systemic lupus erythematosus. Now coming to the cardiac involvement per se, again an important terminology I'll be mentioning. This is the sterile vegetations. Traditionally we read about infective endocarditis, but now we are reading about sterile vegetations that would be developing, and this would be referred to as Libman-Sachs endocarditis. This would be multiplatelet and fibrin deposits on the heart valves. Any heart valve surface can be involved, and traditionally it has a more common involvement, or it has a tendency to involve the inferior surface of the heart valves. And I would like you to listen to infective endocarditis update also, which is in the current version of the app as well, so that you can just be very, very sure about infective endocarditis. MCQ will always come, guys. Pneumonia MCQ will always come, and then pneumonia curve 65 always in NEET exam and in ESET exam and FMG exam. I mean, they love to ask about these endocarditis manifestations as well. So they can be endocarditis, they can be myocarditis. Because of the myocarditis, there can be possibility of arrhythmias as well. And I've already sensitized you to the fact that patients of SLE, because they're having kidney involvement, once kidney involvement becomes severe and the GFR tends to reduce, you anyway have increased incidence of CV mortality, that is accelerated atherosclerosis will occur in these patients. In fact, in current medical diagnosis and treatment, they've described that the mortality in patients of SLE is bimodal. In early years, that is in first 10 years of diagnosis, the usual cause of death is renal involvement and infections. And in these same patients, after 45 years of age, the usual cause of death would be accelerated atherosclerosis. And anyway, the renal disease, as the longer it stays with the patient, accelerated atherosclerosis as a manifestation would be seen. So that would be for the serositis component. And then the next S is relatively easier to remember. That would be skin involvement as well. And this most guys read very well in dermatology as well. So let's just do the formalities here for completion. He is going to write words like subacute cutaneous lupus erythematosus. And the manifestation for this is manifestations of malar rash and photosensitivity. You would be advising these patients that every time they go out in the sun, they have to dab on a very good quality sunscreen lotion with a high sunlight protecting factor. Usually it is recommended, I mean, traditionally what the routine sunscreen lotions which are available are having a sunlight protecting factor of 15, and we recommend these patients to buy those brands where the SPF is going up to 30, because we want to filter out the UV rays, and those UV rays would would contribute to photosensitivity manifestations, where they would almost be, I would say, the burning in the skin would be akin to burning that you get with a first degree burn. You see, if you go out in a hot Indian summer, your skin will literally burn on standing. Burn in a literal sense, it's not going to really burn, but you will feel as if, your skin is becoming hot and you will try to go out into a shade. But once you'll come into the shade, that stinging sensation will go away. But in these patients, even when they come out of the sun into the shade, the burning sensation would still persist and the skin would become red and inflamed. Something like when you are exposed to extreme hot, something like a hot flame, or when you're exposed to a hot scald, where you're making tea for yourself and suddenly that the steam suddenly escapes, and that can cause that skin to become red. I mean, that kind of discomfort that you get on a scald could be experienced by patients of SLE with respect to photosensitivity. So he is going to write words like SCLA, that is subacute cutaneous lupus erythematosus. The manifestations are simple, straightforward. I mean, he's not going to write the word photosensitivity because that's easy for you to pick up the word malar rash. I've already shown you the image for the same. And yeah, in a rush, don't mistake it for malar flush, because I've already explained to you that malar flush is a dramatic manifestation that would be seen with respect to mitral stenosis. So I've just highlighted it with a different color lest you forget this. And the antibody responsible for photosensitivity, I'm just giving you a few seconds without looking at the notes. If you read from pathology, guys, can you tell me the autoantibody seen in SLE which is responsible for causing photosensitivity? I'm waiting for your answer, and I hope that they, usually when they make notes, they tend to jot down everything that I say. I sincerely hope that the editing team does not do that. Yes, guys, testing your pathology. Which antibody in SLE causes photosensitivity? I think I've given sufficient time for you to remember that. And yep, the antibodies, anti-Rho antibody, RO, anti-Rho antibody, which is also called as SSA antibody. So I'll write that down subsequently. I mean, it's very much there in the notes in the later part. But yep, that antibody, anti-Rho antibody, is the one which is villain behind developmentogenesis of photosensitivity. Then another feature that would be described in these patients is chronic cutaneous lupus erythematosus. Here, there could be a couple of other manifestations in the form of a discoid rash or discoid lupus. Now, disc basically means like, a circular lesion like a coin. So what you will notice is that in the periphery where I've drawn this coin or a circle, in the periphery, there would be hyperpigmentation with a bit of redness. And in the center part, there would be hypopigmentation, and along with hypopigmentation in the inside area, you will be having complete destruction of the sweat glands and the sebaceous glands. The adnexa are particularly destroyed here. By discoid lupus, you mean, I'll repeat the features. In the periphery of the lesion, there is hyperpigmentation and redness. So in a white skin, it will look very pronounced. Hyperpigmentation, person is fair and there is a hyperpigmentation circular area that will look very, very pronounced with redness. And in the center area, there's going to be hypopigmentation with the destruction of the sweat glands as well as the sebaceous glands. So the adnexs are destroyed in chronic cutaneous lupus erythematosus. And in fact, they can be damaged to the subcutaneous fat as well. So there might be discomfort. I mean, the subcutaneous area might even be tender sometimes in these patients, or patient might point out to pain in subcutaneous area in some focal areas. That would be paniculatus. So these are like chronic cutaneous lupus erythematosus manifestations. And mostly if he will ask you, he will ask you about SCLE, that is photosensitivity and malar rash. I mean, the terms will be written as SCLE and will not be written as photosensitivity and malar rash. So we're done with the three S's of sonar mnemonic, and now we come to the next manifestation in the SLICC criteria for diagnosis of this condition, and that would be oral ulcers. Most of these patients can be having oral aphthous ulcers, and while I'm writing these oral aphthous ulcers, which may be painful or can be painless as well, if they're painful, no, it will interfere with drinking, or it will interfere with eating spicy food. If you get an aphthous ulcer in your mouth, it can contribute to eating difficulty, especially with respect to eating spicy food. So aphthous ulcers per se can occur in anybody because of stress and constipation. I mean, it can happen with any one of us. But then aphthous ulcers are also read by us with respect to Crohn's disease and ulcerative colitis. We also read about aphthous ulcers involving the genitals with respect to Behçet's disease. I've discussed Behçet's disease in a different part of, in rheumat section only. Behçet's disease is discussed separately, and this would be an interesting topic to read. Silk root disease. Most of the time, this is going to be like a Syrian patient or a Moroccan patient, Iraq. Silk root disease, the traditional one that we used to read about in history. And the patient is on a medical tourism. The person will be having multiple aphthous ulcers. But then in this question, he's also going to talk about genital ulcers as well. Why I'm teaching you this at this moment is to sensitize you to the fact that if you read oral aphthous ulcers, don't only think in terms of SLE, but keep your mind open for a couple of other possibilities as well. And those other possibilities are at the moment marked out in the board. That would be inflammatory bowel disease, Behçet's disease, where genital ulcers would also be described. There would also be hypopyon pus in the anterior chamber of the eye. So there are multiple other manifestations, but the learning point is especially in a patient coming to India on medical tourism, and the question mentions regarding genital aphthous ulcers as well as oral aphthous ulcers, then it's not SLE. SLE does not have a genital involvement with respect to aphthous ulcers, is the key learning point at the moment. The next feature in sonar would be that of alopecia. This would be a non-scarring alopecia. 2 points on this slide, that is, there are total of 3 at the moment. The first and the third point on the current slide are taught in dermatology as well, that lupus would be having non-scarring alopecia and SCLE manifestations are the words which are to be remembered by you. Then alphabet N would be utilized once again because the mnemonic is sonar. So we've taken a care of alphabet S 3 times, O, then N would be coming up 2 times, non-scarring alopecia and neurological manifestations. This disease is not gonna spare anything. Even neurological manifestations can be seen in the form of lupus cerebritis. So no big deal that you can read about headache, you can read about seizures, epilepsy with respect to these patients. So the disease is attacking neurons. We have anti-neuronal antibody which can explain the seizures and the epilepsy that can be developing in these patients. And rarely there is a possibility that this disease can involve the spinal cord as well. So myelopathy can be present, isolated cranial nerve palsies can be present, or even peripheral nerve involvement can be seen. CRN here stands for cranial nerve involvement, PRN stands for isolated peripheral nerve involvement. So that is again a feature that can be seen with the systemic lupus erythematosus. And because there are so many manifestations going on, there's so much going on in the body of this patient, so even the psychiatric manifestations will develop, and that is why he can ask you regarding the neuropsychiatric manifestations, which could be in the form of either depression or development of psychosis. In fact, here a very interesting question will come, that which antibody is responsible for contributing to development of psychosis or psychiatric manifestations in patients of SLE, just like I was teaching you that it was Rho antibody. RO, not gonna write it here because that would be discussed subsequently. But yep, I just told you the data. Rho antibody for photosensitivity. They asked in the exam which antibody is responsible for contributing to psychosis. I'm discussing that antibody name, couple of those names at the moment here only because you see, I will mention the list of antibodies by convention, but there it's a possibility that because so many antibody names I will discuss, you might tend to miss out the key aspect. I mean, what याद क्या करना है? तो सारी एंटीबॉडी तो इतनी सारी हैं. आई मीन देयर यू हैव टू रिमेंबर दो स्पेसिफिक वंस, राइट? सो यहाँ पे जो एंटीबॉडी का नाम होता है उसका नाम मैं अभी लिख रहा हूँ. दैट इज एंटी राइबोसोमल पी एंटीबॉडी. Anti-Ro to short and sweet hai. I know you will remember it, but their anti-ribosomal P antibody is what I usually find people tend to forget. So I want you to remember neurological or neuropsychiatric manifestations can be seen in patients of SLE, and psychosis agar ho gaya, then it's a very big challenge because the steroids also cause psychosis. Steroids also cause psychosis, and disease will also contribute to development of psychosis. So if there is psychosis, then you can't give steroids. Traditionally, whenever you are dealing with SLE or any rheumatoid disorder, you give steroids, na? You give prednisone, you give prednisolone. But here, if there is psychosis occurring, then you would be stuck. Is it due to the steroids that I'm giving? Or is it because of the disease? And that becomes a diagnostic challenge. That's for the rheumat guys to obviously find out. But then the point is that psychosis is a situation which, if is present already, then you're not supposed to give steroids. So we will talk about a couple of other immunomodulatory drugs that would be used for management of these patients. And one I can say right now is hydroxychloroquine. Hydroxychloroquine became famous in COVID now. And every time, whenever we open a book, first time where we read hydroxychloroquine, the current topic. And second time we read it in the literature of rheumatoid arthritis. So that is the N of sonar mnemonic that I've explained that to you at the moment. That is non-scarring alopecia and the neurological manifestations. And now we look at the A of the sonar mnemonic, which would be autoimmune hemolytic anemia. You see, this autoimmune hemolytic anemia can also be written as Coombs positive hemolytic anemia. And in multiple choice questions, he may deliberately write it as Coombs negative hemolytic anemia. So in those all except MCQs, you just need to be a little more careful with respect to remembering the information that I'm saying. Along with this, the autoantibodies would also attack the white blood cells. So there's going to be leukopenia, there's going to be lymphopenia, which will predispose these patients to development of infections. And then over and above this, in case you are dealing with a case of SLE, if a autoimmune disorder will attack its own hemat system, then you can understand the impact of the disease. It's a multi-system disorder causing multiple manifestations, and if because whole of the body systems are getting involved, that is why a patient was getting depressed also. So that would be leukopenia or lymphopenia. That would be a manifestation. And the bad news is even the platelets would be affected. So there's going to be thrombocytopenia, which will explain the development of petechiae. Petechiae देखने में mosquito bite जैसे होते हैं. What is the difference between a mosquito bite and a petechiae is mainly going to be that mosquito bite will blanch. When you will press with the thumb, no, mosquito bite will blanch. But in this particular case, the petechiae are non-blanching in character, and usually due to gravity, they're first seen around the ankles. Coming to the R of the sonar mnemonic, it would be a renal involvement. So let's just quickly revise the manifestations before I say more about renal involvement. The important part here, S was coming 3 times. Try to revise with me. Joint involvement, synovitis. Apart from that, serositis, that was the coverings of the lungs and coverings of the heart, where we talked about the most common and least common manifestations. Then was skin manifestations in the form of photosensitivity. So 3 ho gaya, synovitis, serositis and skin involvement. O is oral aphthous ulcer, easy. N se ho gaya, manifestations in the form of neurological ones. And then lupus cerebritis is an easy way to remember that. Neuropsychiatric manifestations can occur. And N would also be standing for non-scarring alopecia. Then A is for autoimmune hemolytic anemia, and then R is the renal involvement that we see. And because of the renal involvement, what will happen is that these patients can subsequently develop nephrotic syndrome. और कौन से वाला nephrotic syndrome तो बोलना secondary nephrotic syndrome. These patients will develop secondary nephrotic syndrome. See, primary nephrotic syndrome is due to those diseases la minimal chain disease, membranous glomerulopathy, focal segmental glomerulosclerosis. But in this case, there would be a secondary nephrotic syndrome present, and what I'm going to check out in my patient is urinary protein to creatinine ratio. The urinary protein to creatinine ratio in most patients of SLE, if kidney is involved, then this urinary protein to creatinine ratio, it's written as UPCR. This urinary protein creatinine ratio will usually be more than 0.5, which means at least more than 500 milligrams of protein is present per gram of urinary creatinine, or in a 24-hour collection also at least 500 milligram or more of protein would be present. Along with this, because there is a glomerulonephritis component also, so there would be RBC casts present. And along with this, we will also be doing a biopsy, and in fact the biopsy findings in this condition are the most important thing for diagnosis of lupus nephritis. And one of the important findings which is usually asked in the exam as one liner MCQ, you would have read about that in pathology as well, would be wire loop lesions. Normally the urinary protein creatinine ratio would be less than 0.2, but here the value is turning out to be more than 0.5. So that's another way of explaining the proteinuria component. And the same patient in future, I mean, because of the deterioration of these patients in future, there would be development of nephrotic syndrome. Since the glomerular filtration rate will decrease, therefore there will also be a development of decreased GFR, causing a increased renin values, because if GFR decreases, RAS system it will be activated, and therefore there will also be development of hypertension. And the combination of this end stage renal disease and hypertension contributes to accelerated atherosclerosis in these patients. As I've explained to you, if the disease is not diagnosed, you can not only have a renal failure, the estimated GFR can drop to these patients. If I mean that it's itself an MCQ, that GFR less than how much would you classify patient as having a end stage renal disease. Though this term now has been discontinued because it creates a lot of negativity in the mind of patient as well as relatives. When you tell somebody your father has end stage renal disease, I mean, look at the negative vibes that we are giving. So this term has now been discontinued. I mean, we discourage using words like ESRD. We'll just say mathematically, estimated GFR is less than 15 ml per minute, 1.75 meter square of body surface area. But still, from the exam perspective, they can put up this data before you. End stage renal disease is defined as estimated GFR less than 15 ml per minute, 1.73 meter square of body surface area. And if relatives are asking ki kya hoga if we do not agree for any intervention, the person will go into uremia. There would be uremic encephalopathy, uremic pericarditis. And while you were listening to the discussion, you would have realized the amount of problems that Selena Gomez would have gone through. In fact, I did mention Serena Williams. Serena Williams is a very prominent tennis player for last, 10 years or so. She has been a powerhouse of Grand Slam, winning Australian Open, French Open, and in lawn tennis. And even she, blacks have increased CV problems, no? So even Serena Williams, after her delivery, she developed deep vein thrombosis and she developed pulmonary embolism so bad that she almost died. I've described that in the pulmonary embolism video as well for Serena Williams, that blacks tend to have increased cardiovascular issues, and that is why she ended up with the PE, pulmonary embolism. And SLE patients here I have given example of the brand ambassador for Lupus Foundation at the moment, the pop singer. And why I'm saying this again and again is, guys, not because I want to talk about that pop singer. What I'm trying to tell you is she's a millionaire, or a billionaire in fact. If she has so much of money, she can afford and see any doctor. And if she can see so and any doctor at any point of time, see, she is in the most developed country of the world with the most advanced medical health care, and she was going through so much and still it was not diagnosed. So rheumatic diseases per se are always a diagnostic challenge. You need to follow up with the same doctor over a period of time before a rheumatic disorder can be diagnosed. And if a patient will do doctor shopping, which is very common in India, that they show a doctor, they'll change a doctor, go to a third one, there is a probability that this can be missed. So I'll repeat once again, guys, why I'm giving you the example of these celebrities is not because that I'm interested in trying to tell you that, okay, this celebrity got this disease. That's not the perspective. They belong to a country where the most advanced systems are in place. And in spite of that, that system was not able to pick it up in spite of all these problems in sonar that you're seeing. I mean, it's not a small thing to have a pleuritis that will cause chest pain. It's not a small thing to have a pericarditis that will again cause chest pain with ECG changes. Plus the joints would be hurting. There could be aphthous ulcers developing. There could be loss of hair. For this, the patient would have gone to a psychiatrist. Then patient would have gone to a dermatologist. Whereas what was required was somebody who could assimilate all of these. They were going to different specialities, but that interlinking of specialities did not happen, which is the reason why the disease remained undiagnosed to the level that the person ultimately required a kidney transplantation. So that is why it's a diagnostic challenge. And at this moment, I've tried to explain to you what are the clinical criteria which are required for diagnosis of systemic lupus erythematosus. These are the older guidelines, guys, SLICC criteria. And what I want you to remember is that at the moment, what I've explained to you are only the clinical criteria. What will follow in the subsequent slide will be immunological criteria or immunological features of the disease. And from the exam perspective, if they ask you from the SLICC criteria that how many criteria are required overall for diagnosis of SLE out of all of them that I've explained, then he says total of 4 manifestations should be present, out of which at least one clinical and at least one immunological feature should be present. Let me explain this again. He's saying total of 4 features should be present. Now, out of these 4 features, it can be like 3 can be clinical. By clinical, I mean this lady is having anemia, she's having a malar rash, she's having a joint pain as well. And the immunological features is the anti-nuclear antibody that is turning out to be positive. That will make it 4 no. A young lady came to you and she's having progressive anemia. She's saying, sir, I'm taking iron tablets and my hemoglobin is still very low and it's decreasing, decreasing, decreasing. You are finding evidence of hemolysis present. Normocytic normochromic anemia, LDH values are rising because there is a hemolysis occurring. At the same time, she's also having photosensitivity and a malar rash. And then she's also started to have development of joint pain as well. So there are 3 clinical features. Plus she's having anti-nuclear antibody that's turning out to be positive. That will become total of 4. So it says total have to be 4, out of which at least one clinical. That's the word to be remembered. At least one clinical and at least one immunological criteria. I'll just write a short form for immunological one. I've written the full form at the moment. At least one immunological criteria should be present. So it can be like the person is having only one clinical criteria with 3 laboratory features. Laboratory features can be like anti-nuclear antibody, anti-Smith antibody, double-stranded antibody, double-stranded DNA antibody. Like it could be one clinical feature with 3 antibodies, or it could be 3 clinical features with 1 antibody present. But total you need 4. टोटल आपको 4 पॉइंट्स चाहिए, जिनमें से कम एक क्लिनिकल और 3 लैब हो सकते हैं, लेबोरेटरी फीचर्स और इम्यूनोलॉजिकल फीचर्स दैट आई एम गोना मेंशन, और लाइक इंस्टेड ऑफ हैविंग लाइक 1 clinical and 3 labs, it could be vice versa. It could be 3 clinical and 1 lab that is positive, and most of the time anti-nuclear antibody will be positive. You see, earlier I was saying entry level criteria. That entry level criteria is for the subsequent criteria, the ACR ones that I'll talk about, the 2019 wale criteria. Abhi, what I'm trying to teach you at the moment are the relatively the older criteria for diagnosis of this condition, that is SLICC ones. Let us now make a list of immunological features which are to be remembered. One of them is going to be anti-nuclear antibody, which would be more than the reference limits. That would be more than 1:80 titers by immunofluorescence. Another one is antibody to double-stranded DNA. This test or this antibody usually helps in monitoring the disease severity, because the values tend to rise with the disease flare and then tend to stabilize once the disease will get controlled with medication. One of the very specific antibodies for diagnosis of this is called as anti-Smith antibody, which is written as anti-SM antibody, with alphabet S being capital and small being relatively small. And then you will also notice that a lot of these patients might be having problems with respect to being able to maintain a pregnancy. You see, she will conceive, but then she may not be able to continue the pregnancy. There could be a possibility of either recurrent abortions, or there could be like intrauterine death at 34 weeks. She might be suffering from preeclampsia, and you will read about antiphospholipid syndrome in the later part of the discussion. But what I'm trying to say at the moment is that the villain which is responsible for that bad obstetric history in a lady with SLE is antiphospholipid antibody. The antibodies which are present here are a couple of them. One of them is lupus anticoagulant. And what these antibodies that I'm going to teach you now are going to cause is that they're going to cause the clotting cycle of the body to go into automatic mode. Because the clotting cycle, you see, normally we need to have trauma. Like if you're shaving in the morning, you get a cut from a shaving razor. That is when the clotting cycle tends to form a clot. But here, without any trauma, patient is sitting on a chair talking to you, and the antibody in her body is working and is setting the clotting cycle into automatic mode, which would result in development of a placental infarction. And because of this placental infarction, you could be having intrauterine deaths, or they could be even recurrent abortions developing as well. So you will have to remember the name of the antibodies. That's lupus anticoagulant. Another one is anti-cardiolipin antibody, for which we'll do a ELISA test. Another one is anti-beta 2 glycoprotein antibody. There is a possibility that here he might try to just play around with words, because the word is anti-beta 2 glycoprotein 1 antibody, and he might write words like beta 2 microglobulin, etc. So I think it's pretty, I have made it very obvious. It's anti-beta 2 glycoprotein 1 antibody, again checked by ELISA, and contributes to placental infarctions. It causes the clotting cycle to go into automatic mode, and that is why you will notice deranged prothrombin time and activated partial thromboplastin time in these patients. Then because she is having a bad obstetric history, you are aware from your obstetric classes that one of the reasons for bad obstetric history can be syphilis as well. So when you'll be running tests on this lady, you will notice that sometimes even RPR, that is rapid plasma reagent or VDRL test, will turn out to be positive. And when you will tell this lady that this test is positive, and she just googled about RPR or she just googled about VDRL, and she read that it is about syphilis, she's from a good background, and she's asking you, sir, are you serious? You trying to tell me that I have some STD, and that is why I'm having this recurrent abortions? And she says, like, I mean, she's from a good background, and there is absolutely no reason why she could be having a STD like syphilis, which is a disease of I would say 18th or 19th century. So you will tell her, ma'am, that this test for syphilis is turning out to be false positive in you, because these antibodies that I mentioned superiorly tend to react with the kit for RPR or VDRL as well. And that is why false positive tests for syphilis can be present in patients of SLE who are having a bad obstetric history. The reason for these are the antibodies which are mentioned here, and the broad term for this would be called as secondary antiphospholipid syndrome. I mean, when SLE is associated with bad obstetric history, when there are placental infarctions occurring, they could be PIH, they could be eclampsia developing, they could be recurrent abortions happening. And this is just the tip of the iceberg, man. You will notice in the later part of the discussion, when I describe antiphospholipid antibody syndrome to you, this disease can cause MI. It can cause stroke. I mean, this lady might be on lifelong low dose aspirin. At 25, 30 years of age, imagine you're telling a young lady, ma'am, I request you to take low dose aspirin on regular basis for remaining whole of your life, because you can have a MI or you can end up with a stroke. So, I mean, that's the disability that we get with antiphospholipid syndrome, which will be discussed once we finish this topic. But since the name came up, so it was important for me to talk about the antibodies which are playing a villain here, and they can cause a false positive test for STD, that is for syphilis as well. But that's because of the cross reaction with the kit by the antibody. Now, in the beginning of the discussion, I said it's a type 3 hypersensitivity reaction, immune complex formation. So immune complexes, will activate the complement. And once the complement system is activated, it will be consumed. So you will also read about low serum complement. The values of C3, the values of C4 and CH50 will found to be low. And the reason for this complement system being low is that they are consumed in the process of autoimmunity. I mean, the disease is not sparing anything. It's attacking self RBCs, it's attacking sebaceous glands, sweat glands, it's causing extensive hair loss in a patient. And as I explained, because there is an autoimmune hemolytic anemia, so he might even say the word positive Coombs test. That is a direct Coombs test that would be positive in this case. And in questions, it could be deliberately written as a Coombs negative hemolytic anemia, whereas in this particular case, it's a Coombs positive Coombs test. And I would also like to mention the page number from Harrison, because I know that I'm going to get a lot of queries from you. My email ID is marvamedicine@gmail.com. You can drop me a mail for this, because you see, when you will do MCQs from different platforms, they'll be saying exerted atherosclerosis is the leading cause of development of death. But here I have mentioned page number of Harrison, that's from the 21st edition of Harrison, S21, and it says that nephritis and infection are the leading causes of mortality in the first decade. So, controversies will remain. We need to keep a positive mindset for it. But then, different authors could be having different views on the same disease, because as I also said, kidney disease subsequently causes accelerated atherosclerosis, but he's not written that word. He's written this word, leading cause of mortality in first decade is nephritis, as well as infection. And the reason for infection also I've explained. One is the aspect of treatment, because you would be using immunomodulatory drugs. And the second reason why that could be happening is because of the fact that there is a very distinct lymphopenia that is seen in these patients. So the combination of the two can explain the reason for development of mortality in the first decade for these patients. Most of the time, the lupus nephritis that develops in these cases would be class 3 or class 4, or can be class 5 as well. So for class 3, we usually use the word focal lupus nephritis. If it is going to be class 4, we call it diffuse lupus nephritis, and if it is class 5, we tend to call it membranous lupus nephritis. So I'll just jot it down here as well. The various classes of lupus nephritis that you need to remember, that would be class 3, 4, 5. Why they are ones that are being told to you is because this is where aggressive treatment needs to be given. It is FDM. You see, we put a FD in the bank now for earning money. So that is how you can remember it. FDM. I'll repeat that again. You put FD in a bank to earn money. So you can remember FDM for remembering focal lupus nephritis. LN here is lupus, not lymphadenopathy. Traditionally, I write LN for lymphadenopathy, but now I'm writing LN for, I'll just put a mark also here. The LN here is to represent the word lupus nephritis. And why is only 3, 4, and 5 being discussed? Because they are the ones where aggressive treatment with mycophenolate and calcineurin inhibitors like tacrolimus is given. He says for 1 and 2, you don't start immunosuppressive therapy because the disease is just starting. So you want the disease to, adapt a particular format. I mean, this is what clinical trials have shown, that with FDM, the interventions will work and will tend to reduce mortality as well as morbidity. And at the same time, once he goes into end-stage renal disease, that is when he goes into class 6, then he says in class 6, there is no rule. In class 6 of lupus nephritis, there is no role of steroids. I repeat that once again, guys. In class 1, 2, and 6, there is no role of administration of steroids. It is only in class 3, 4, or there is no role of immunomodulatory treatment, in fact. And nowadays, from the main treatment perspective, I mean, instead of steroids, is recommending that you go more aggressive. Earlier times for lupus nephritis, we were using steroids. We still use them. It's not that we are not supposed to use steroids, but the aggressive management, if we are knowing that the organ is getting damaged, I would like to, put on more pressure. I would like to use more aggressive drugs. That is why for lupus nephritis, the recommended regimen as given in the flowchart in Harrison is combination. I'll write that down in the treatment part, is mycophenolate with tacrolimus. Though we can use steroids as well in a low resource cost settings where person is not able to afford expensive drugs, we can use steroids also. But when would you use immunomodulatory treatment is important. We do not use it in 1, 2, and 6. You don't waste your firepower. You use it where the firepower is required, which is why this data has been mentioned with respect to class 3, 4, 5, where interventions need to be done. And if not, then the deterioration will occur and the person would require either a transplantation or a hemodialysis. Next, the image that you're seeing at the moment is the 2019 ACR EULAR criteria for diagnosis, the latest criteria for diagnosis of systemic lupus erythematosus. And I've already spoken about it, but I thought I should show an image for the same as well. You're not supposed to memorize it, but yep, you should be knowing that anti-nuclear antibody values at titer more than 180 is referred as an entry criterion. And then there will be varied manifestations which would be taken into consideration, ranging from constitutional symptoms to neuropsychiatric, mucocutaneous, serosal, musculoskeletal, renal involvement. Similarly, the complement system, each of them is being given a point. And if you focus at the lower part of the discussion, you can see that class 3 and class 4 nephritis is given maximum score of 10 points, whereas all other, you scroll through it, the data, you will notice that all are given a score of 2, 3, or some are giving a score of 6 also. But then the maximum weightage is for renal biopsy, and that was a question in the exam, that according to the latest criteria, which parameter is given maximum weightage for diagnosis. And I did mention that in the initial part of the discussion itself. We'll have a quick revision for the antibodies, though you know it from pathology as well. Anti-nuclear antibody, the titers have to be in excess of more than 1/80 by immunofluorescence method. And this happens to be the best screening test for diagnosis of this condition. From basic sciences, you know that the sensitive test is the one which is best for screening as well. So the screening test for diagnosis, entry level criteria, I mean 3 MCQs where I've said anti-nuclear antibody to be present, entry level criterion, most sensitive test, and screening test for diagnosis of SLE. As far as double-stranded DNA is concerned, high titers, he says this word, that high titers are specific, but that basically means the fact that if in the early part of the disease the titers are low, then it would not be specific. So what is the importance of doing this test? If only high titers are specific, then what you need to remember is that the advantage of doing this test is that it will correlate with the disease severity or disease activity. Like if you're having a flare up of the disease, then the values will tend to rise, and when you will treat the patient, the values will tend to come down. So to monitor the progression of the disease, we'll be using double stranded DNA. Otherwise, the most specific test for diagnosis of this condition would be answered as anti-Smith antibody. And double stranded DNA specific word is written in the textbook, but he's saying this word high titers only are specific. He's mentioned this word only high titers are specific, whereas the most specific test is anti-SM, that is anti-Smith antibody. Now, anti-C1q antibody is a star mark in front of it, though it is seen in only 60% of the cases. But the point is that this is seen in only 60% of the cases, but tends to correlate with the severity of lupus nephritis, which is one of the important causes of mortality in this condition. So if he puts up a question like this, that what test will talk about diagnosis of lupus nephritis, then you obviously need to do a biopsy. Indirect markers will obviously be hematuria and RBC cast present and UPCR, urinary protein creatinine ratio. So all those indirect markers to assess disease activity will be very much present. But then renal biopsy would be the best way to say that, okay, the kidney is damaged and this is the grade of damage present. But if I want to monitor the progression of damage, if I want to check out the severity of lupus nephritis without doing a biopsy, then what is the test that I have without doing a biopsy? The test is anti-C1q antibody. I repeat that once again. For severity of lupus nephritis, the ideal method would be to go ahead with a biopsy. Otherwise, I have non-invasive methods also. I can check for urinary protein creatinine ratio on a serial basis. It will keep on rising. Kidney swelling, serum creatinine will start rise. So kidney parameters will keep on getting deranged in a person. But before that bad things start happening, I mean, I'm not going to wait for that creatinine to become 4 milligram. I will monitor the damage to the kidney with help of this test, that is anti-C1q antibody. The handicap for this antibody is positive in only 60% cases. Then for anti-Rho antibody, this is not very specific for diagnosis of this condition, but has an alternative name as well, that is SSA antibody, which is to be remembered. And then this antibody can contribute to the development of photosensitivity, which was already told to you in the earlier part. And next that I say would be the most, I would say, outrageous statement that I'll be making for this disease, that the autoimmunity in this disease will not only affect the lady, but even her fetus. I mean, imagine the attack of autoimmunity that a fetus will also be affected. And how will the fetus be affected? The antibody will go and damage the AV node of this child. You see, the current impulses in a heart go from SA node to the AV node to the bundle of hairs, and the antibody in this case is going to cause extensive damage to the AV node. And because of this damage to the AV node, what will happen is that the impulses will not able to go down, and therefore this fetus will develop a condition that is called as third degree heart block, or is also called as complete heart block. Now, heart blocks are something that we tend to read in old age group, but here we are seeing a newborn baby being born with a complete heart block, and because the heart rate will be hardly 40, this child will usually die after birth. He might require a pacing, or the child will die immediately after birth, because the heart rate would hardly be 40 or less than 40 beats per minute. So complete heart block can occur, and therefore this manifestation is referred to as neonatal lupus. Look at the impact. The baby will be suffering from what the mother was suffering from, not in a sense that the same manifestations at the moment, but yep, he's gonna suffer from a heart disease. And though the incidence of this is less, but still, because this is less common, that is why this is asked in the exam, that which antibody will be responsible for causing heart block in a baby born to a lady with systemic lupus erythematosus. Your answer is anti-Rho antibody. So photosensitivity and complete heart block both have to be remembered. And if you are an FMG student, you think that this is too much to remember, guys, they've asked this in your exam. It's not an easy one anymore. I mean, they put up pressure on your mind, so you need to remember this data. So everything that I'm saying, sir, for both exams, whether it's FMG or NEET PG, data has to be remembered. Only thing is, in NEET PG there is negative marking. In FMG it's a slightly more easier exam, I agree to that, and but then negative marking is not there. That's the only bonus point. So you tend to go a little easy, but then the real data are also being asked. Then for anti-LA antibody, just an alternative name is to be remembered, that is SSB. and there is unlikely to be a question to be put on the same. Questions are more likely to come where I put the star marks present, and then is anti-histone antibody. This needs no introduction. Everybody knows about this. Anti-histone antibody would be for drug-induced lupus. Well, the mnemonic for this would be drugs by the name of SHIP. The mnemonic SHIP would be for S would be for sulfur drugs. H would be for hydralazine. This is a vasodilator that can be used for patients who are having hypertensive crisis. Then isoniazid, and then is procainamide. Procainamide has been discussed for management of Wolff-Parkinson-White syndrome. Yes, the same molecule that's used in acute episodes of WPW syndrome, where a bundle of CAD is procainamide, and that can be contributing to drug-induced lupus and would be related to anti-histone antibodies. So that's a list of antibodies that you need to remember, and it's not over yet because he's gonna ask you about antiphospholipid antibody. In antiphospholipid antibody, couple of names I've already told you. So let's just do a quick practice here. I know this would be a repetition, but I just deliberately want to do this with you. One is ELISA for cardiolipin, one would be ELISA for beta 2 glycoprotein 1 antibody. And the importance of these would be that they'll trigger placental infarctions, they'll cause bad obstetric history, they can cause recurrent abortions or development of intrauterine death in the patient as well, and thereby we will be having placental infarctions. One of the most important antibody to be remembered here is lupus anticoagulant. This name itself is a misnomer, no anticoagulant, but it is not causing bleeding, it is rather causing a clot formation. And one of the tests that is done with the lupus anticoagulant demonstration is called as dilute Russell Viper. I mean, when you write this test, no, patient's eyes will literally widen. If educated patient is there, sir, what are you writing, a snake-based test? I'll be explaining the logic and rationale behind this test with respect to antiphospholipid antibody syndrome. But at the moment, I want you to be sensitized to a dilute Russell Viper venom time test. So it's written as DRVVT, that is dilute Russell Viper venom time test. Traditionally, the Viper venom will contribute to clot formation, but because of this antibody, I mean, that clot formation process can be hampered as well. So dilute Russell Viper venom time test, or DRVVT, is an indirect test that's used to demonstrate the presentation of lupus anticoagulant. And these antibodies are the ones which are ultimately responsible for clotting. They're responsible for development of recurrent fetal loss or even intrauterine death. Most of the time, the fetal loss will be occurring at 34 weeks of gestation, and the abortions most of the time would be occurring before 10 weeks. It would be first trimester abortions as well. Then anti-erythrocyte antibody, I don't think so you need to remember, because this would be causing autoimmune hemolytic anemia. So max you can write that Coons negative hemolytic anemia that I've sensitized you to. Antiplatelet antibody will contribute to thrombocytopenia. They can be even bleeding. They could be petechiae. It could be mucocutaneous bleedings as well. Then antineuronal antibody will contribute to development of CNS lupus that will explain the seizures and even epilepsy, headache, cognitive issues, mood problems that could be developing. And then anti-ribosomal P will be responsible for neuropsychiatric manifestations. They can be two of them. It can be depression. It could be development of psychosis. So if he says which antibody, again a very peculiar question, antibody causing development of psychiatric manifestations, then it would be anti-ribosomal P as far as lupus neuropsychiatric manifestation is concerned. This table, guys, that I mentioned at this particular point of time is the most important part in SLE. I mean, if you don't remember the remaining clinical features of SLE, cool, chalega, you still be able to clear and get all the question right, because he will mention about anti-nuclear antibody. And couple of manifestations are very classical for this topic: shrinking lung syndrome, Libman-Sachs endocarditis. Those terms you know from pathology itself. So if you get the antibody data right in rheumat, you are bang on track to get these questions right, because even a rheumatologist cannot make a diagnosis of this condition without an anti-nuclear antibody. ANA is an entry-level criterion. Next up is pregnancy and lupus, and the question would be, what is the best drug for management of active SLE in pregnancy? Then your answer should not be given as steroids. I'll give you the reasons for the same as well. Well, the reference for this is page 2747 from Harrison. He says first line management for active SLE in pregnancy is hydroxychloroquine. He says at the discretion of a doctor, in case it is required as a last resort, you can be using steroids as well. But then the query in your mind would be that if steroids are going to be first line for routine flare-ups of SLE, then why not for pregnancy? Well, there are two reasons behind it. The first reason is that there is a placental enzyme by the name of 11 beta dehydrogenase, and the problem with this enzyme is that it is going to cause deactivation of the steroids. So even if you are going to be giving steroids to this patient, it would be a waste of resources because the medicine will get deactivated. And the second problem is that steroids do pose a fetal risk as well, because the Federal Drug Authority will test every drug to determine whether it is safe in pregnancy or not. You see, there are two aspects that I'm saying. One, I said the placenta will deactivate the steroid, so majority of it is going to be a wasted molecule. And whatever that will remain, that will not be deactivated, that might cross over to the placenta, and then it can transfer to the baby and can pose a fetal risk. So due to a combination of these two facts, one, the medicine is getting deactivated, majority of it, and some part that might be transmitted from a pregnant lady with SLE to her baby, poses a risk to the fetus as well. As a result of it, due to combination of these two, he says that would be steroids would be a backup, and the initial management would be hydroxychloroquine. The second aspect that is usually asked is antiphospholipid syndrome, though I'll be describing this separately once I finish this topic. But then antiphospholipid syndrome can be existing without SLE also and with SLE also. If it is existing with SLE, we call it secondary antiphospholipid syndrome. The problem in this case would be recurrent abortions, or it would be intrauterine death. So there's a fetal loss that is happening due to placental infarctions that I was explaining to you earlier. So the question that would be asked to you will say that what is the management for obstetric events, because this lady is having a bad obstetric history. So for management of this obstetric antiphospholipid syndrome, one, we'll have to start the patient on low dose aspirin, and the second molecule that would be started is low molecular weight heparin. Initially, the dosages that we'll be giving would be prophylactic dosages, but in case the miscarriages continue, we can increase the dose of heparin and go into therapeutic range as well, because these patients are having tendency to have development of uterine artery and venous thrombosis. That is why there was a placental infarction developing, and that could explain the development of fetal loss in these patients. We will now be focusing on what is the treatment for SLE, and is subdivided this into two categories, that is not organ or life threatening versus life or organ threatening. So as far as not life or organ threatening but still manifestations are there, he says that you will have to adjust the dose of steroids and put the patient at the lowest tolerated dose of steroids. Whenever we give steroids, we should be giving it a single dose. Because of the gastritis component, a lot of us might try, from the patient's perspective, we might try to give it in divided dosages, but you're aware that if you give steroids in divided dosages, that increases the risk of development of Cushing syndrome. So he says that give it as a single dose only in the morning to mimic the biological profile, and low dose glucocorticoids would be the mainstay of treatment in case there is no threat to life. If there is threat to life, then we have to be a little more aggressive, so I'll talk about that also. But there are a couple of biological approaches which would also be recommended. So one of the molecules that you need to remember from the exam perspective is belimumab, that can be given to those patients in case steroid toxicity is present or steroids cannot be tolerated, mainly because of the GI side effects. Now, if there is life or organ threatening, either of the two situations, and he says what will you use, then you will have to, one, increase the dose of steroids. The toxicity part will also go up. And the second molecule, because alone steroids may not be sufficient, so he says that you should be combining this with mycophenolate. In some books, he also does mention regarding cyclophosphamide as well, so I'll jot down the name. Though the side effect profile of cyclophosphamide will be having a lot of dismal side effects, which some patients may not be able to tolerate as well. But that is the approach, because the disease is more aggressive. So I will also be more aggressive, and I'll be using high dose steroids with either mycophenolate or cyclophosphamide, and the preference first would be for mycophenolate. But if he specifies person is having lupus nephritis, then I've already explained to you that in lupus nephritis, it is going to be class 3, 4, 5, where the treatment would be recommended, and not for class 1, 2, and 6. So for lupus nephritis, the drug treatment that would be used is mycophenolate. And the second drug category that would be used in this case is calcineurin inhibitors. So one of the calcineurin inhibitors, the very famous one that you're aware of, is tacrolimus. That would be the best approach for management in lupus nephritis, which would be contributing to increased risk of mortality in these cases. Next is antiphospholipid syndrome. So, well, what is this disease per se? This is an autoantibody mediated thrombophilia, which contributes to increased chances of clot formation. And most of the time any body organ can be involved, but majority of cases will end up with development of recurrent episodes of deep vein thrombosis, which can cause pulmonary embolism. Some cases can be having Budd-Chiari syndrome. Bad news is some patients can have MI and some can be having stroke as well. So that's a horrible thing to say to a 25-year-old lady, that you in future can have a MI, you can have a stroke, and she might have had suffered from recurrent deep vein thrombosis episodes as well. Antiphospholipid antibody syndrome is either written as primary or is written as secondary. Secondary whenever it is associated with a connective tissue disorder, and usually in about 20% of cases it would be associated with systemic lupus erythematosus. Any body system can be involved, but if at least 3 or more body systems are involved, like for example heart is involved because there was a MI, the same patient in future developed a stroke as well, and then she was having bad obstetric history as well, or she ended up with distal ulcers, or she ended up with Budd-Chiari syndrome, the liver got involved. So if we are having at least 3 or more than 3 organs involved in antiphospholipid syndrome, then we use the word catastrophic. I mean, it's self-explanatory, so many body organs getting involved. So that is why we will use the word catastrophic antiphospholipid syndrome for CAPS. And at this junction, I want also you to remember that when would you be suspecting antiphospholipid antibody syndrome, then the situations would be if less than 55 years of age, a person is suffering from stroke or cerebrovascular accident, you should be suspecting, because a older patient, he's ending up with stroke. It could be cardioembolic stroke, it could be atherosclerosis of the brain blood vessels. But at a younger age, if somebody is suffering from stroke, then one of the conditions to be suspected, especially in a young female, would be antiphospholipid syndrome. The second scenario would be if there is development of recurrent episodes of thrombosis. This could be deep vein thrombosis contributing to pulmonary embolism, Budd-Chiari syndrome. Even in the workup of Budd-Chiari syndrome, antiphospholipid antibody syndrome is discussed. Even in when you listen to pulmonary thromboembolism in RESPI, I've said the word antiphospholipid antibody syndrome. And then the third reason would obviously be with respect to pregnancy. In fact, from the pregnancy perspective, I can say there are multiple reasons why we can be having mortality of a fetus with respect to pregnancy, or there can be recurrent abortions as well. But if there is a pregnancy related morbidity and a couple of clinical clues present. Now, what is the clinical clue that would be present? One could be a skin manifestation by the name of livedo reticularis. I'll show you the image of livedo reticularis as well, but this would be a fishnet appearance of dilated blood vessels on the skin. Just like a fishnet will have, these appearance. Similarly, dilated blood vessels will be seen on the skin. There are multiple reasons for livedo reticularis. Usually you read about livedo reticularis with polyarthritis nodosa, but the same livedo reticularis can be present in antiphospholipid antibody syndrome as well. So if there is a pregnancy morbidity and the lady is having livedo reticularis, that is a clinical hint. Another hint would be because there is recurrent clot formation in the uterine artery, uterus venous circulation, and due to the platelets getting consumed in the process of clot formation, there would be a thrombocytopenia. I'll say this fact once again. Just like in DIC, there is multiple clot formation and therefore the platelets get consumed, and you refer to DIC as consumptive coagulopathy. In the same spirit, I'm saying that even in antiphospholipid antibody syndrome, the clotting cycle goes into a haywire mode. What I mean by clotting cycle going into a haywire mode is that the clotting cycle is going into automatic mode and is causing clot formation. In you and me, the clotting cycle is activated when there is some kind of injury. Like you're shaving in the morning, you get a cut from a shaving razor. That is when the clotting cycle gets activated. But in these patients, even without any external trauma, there would be still activation of the clotting cycles, because of which prothrombin time, activated partial thromboplastin time would be increased in these patients. And the query in mind of a lot of students is, sir, why do you call it antiphospholipid syndrome? Guys, phospholipid is present in the cell membrane of every cell in the body, including endothelial cells. Every cell in our body would be having cell membrane, and cell membrane has phospholipids, and this autoimmune condition is attacking the phospholipids in the cell membrane. Most of the time, from the pathological perspective, there are multiple antibodies which are present here. Antibodies which are present here are like anti-cardiolipin antibody, anti-beta-2 glycoprotein 1 antibody. All these antibodies which are present here, and the names of which are said verbally, and I'm going to write it down subsequently. The names have been said in the earlier part of the discussion also. Anti-phospholipid antibody, anti-cardiolipin, anti-beta-2 glycoprotein. Those antibodies, what they're doing is they're causing an enhanced apoptosis of endothelial cells. and the phospholipids in these endothelial cells are getting exposed to these antibodies, and that is the trigger which is ultimately activating the clotting cycle. I said two aspects. One, I said the antibodies will attack what is a basic fundamental product present in cell membrane of every cell, that is phospholipids, plus there is increased apoptosis of endothelial cells. I mean, endothelial cells, whenever they are damaged, clotting cycle will be activated, and due to the activation of the clotting cycle, you will notice in the later part of me saying that prothrombin time of these patients is deranged, activated partial thromboplastin time is deranged, and there would be consumption of the platelets for the formation of these clots, and that is why thrombocytopenia was described. So when do you suspect it? Young lady with stroke, young lady who's having a MI, thrombotic events, that could be venous thrombosis, pulmonary embolism, Budd-Chiari, or pregnancy morbidity in a setting of the aspects that I have mentioned. I mean, these are the scenarios where antiphospholipid syndrome should be suspected, and then we will study regarding the clinical criteria and the laboratory criteria for diagnosis of antiphospholipid syndrome. We need at least one clinical criteria and one lab criteria to be satisfied. Let's first fill up the clinical criteria. The clinical criteria number one would be vascular events or vascular thrombosis that would be developing. This vascular thrombosis can be involving an artery, it can be involving the vein, it could be involving the smaller blood vessels also. The disease could be affecting the arterioles as well. So any artery, any vein, any small blood vessel which is supplying any organ or tissue in the body is the one which can be affected, and because of which such gross manifestations can be seen. There is a thrombosis developing in the hepatic veins, which will progress to involve the inferior vena cava, so liver is getting involved, Budd-Chiari syndrome. There can be deep vein thrombosis, which can subsequently cause dislodgement of the clots. The clot was formed in the soleal vein or in the popliteal vein, and then the clot will get dislodged, and this clot will move up retrogradely towards the heart, and it will cause development of DVT, that is deep vein thrombosis, contributing to pulmonary thromboembolism. At a young age, this lady might suffer from stroke, she can suffer from myocardial infarction, there can be digital ulcers in these patients, there can be digital gangrene in these patients as well, that might even require an amputation. Even the retinal circulation can be affected. So retinal artery thrombosis can explain blindness. There would be also CNS aspects, in the sense that there would be headache, there can be seizures developing in these patients. So it's a myriad manifestations, or a large number of manifestations, including hemat manifestations, can be present in the form of autoimmune hemolytic anemia and thrombocytopenia. The antibodies would be causing destruction of self RBCs. Therefore, Coombs positive hemolytic anemia can be a term used to describe the autoimmune hemolytic anemia which is present here. Apart from the vascular thrombosis component, the second would be the standard pregnancy morbidity. And point number two that I am saying at the moment would have been read by you even in your obstetrics or OBGY discussion. So this should be serving as a revision for you guys. I mean, one possibility can be that this lady says that everything was going fine, and then one fine time, or like, just 1 month before the delivery, she had to undergo a premature termination of pregnancy, and she had to deliver a preterm baby who maybe had lung immaturity, and the baby had to spend a couple of weeks in the neonatal intensive care unit as well. And the reason why the preterm baby was born was because of either that she was having preeclampsia or she was having eclampsia. So in a setting of placental infarctions, there can be PIH or eclampsia developing, which might require a termination of pregnancy. And in some cases, if this is not done, there can be intrauterine death as well. So the another manifestation that we read is unexplained mortality. I mean, she just says that on a weekend, I could not feel my baby moving, like she's 20 weeks pregnant. And she says like there is a quickening that happens in pregnancy and the mother can perceive the baby moving. And she says that the baby was not moving. So it was a weekend. I did call up my obstetrician because she was worried that the baby's kicking movements are not being perceived by her. And she says the gynecologist on a weekend said that, okay, come on a Monday. And when I went on a Monday, they did a Doppler and they just told me rudely, my baby is dead. And she says like, I got the shock of my life, doctor. And this is not the first time that this has happened with me, that I had to, undergo the process of delivering a baby, because otherwise they told her that she'll develop DIC. So unexplained death of a morphologically normal fetus, because traditionally the thought process of everybody would be that, you see, the pregnancy went bad because there was some malformation in a baby, like in an anencephaly, craniorastosis, myelomeningocele. If there are defects in a baby and the baby is aborted, it's understandable. Or another reason for abortion could be trisomies, trisomy 16, trisomy 21, Turner syndrome. We do read about, syndromes being responsible for abortions as well. But in this case, she's saying, sir, there was an unexplained death of a morphologically normal fetus. I mean, she is totally aghast, and a non-medico will not be able to understand this also, that if there is no malformation in the fetus, even then the baby got aborted, or I lost my child. So she's asking you, why is this happening? And you will tell her, ma'am, this is because you are having autoantibodies in your body that are causing the clotting cycle to go into automatic mode, and thereby they're contributing to placental infarction. And if the placental blood supply is hampered, well, there would be disruption happening. So unexplained death of a morphologically normal fetus. There's no CNS or cardiovascular or any kind of malformation present in a child, but we're still losing it because of the placental infarction present, or there could be prematurity. Or she might say that I'm having difficulty in conceiving. She says that there has been 3 or more than 3 unexplained consecutive spontaneous abortions. And she says that I've been to various gynecologists and they've not been able to offer me any routine explanation. And sometimes it's a possibility because syphilis is also one of the important causes for development of spontaneous abortions. So she might have got a VDRL test which might have turned out to be positive. I've said this in the earlier part of the discussion also, that patients of antiphospholipid antibody syndrome can be having a false positive VDRL. And because of this false positive VDRL, this Leadable quiz user, she's from a good background, and she says syphilis, are you telling me that I'm having a STD which is causing this unexplained consecutive spontaneous abortions? And you will tell her that, no ma'am, it is not that you are having any STD. It is the antibody in your body that is cross-reacting with the kit for VDRL, which would be responsible for false positive VDRL in these patients. Now let's look at the lab criteria. There are 3 of them that are to be satisfied. The first lab criteria to be remembered would be LA, that is lupus anticoagulant, for which we'll be doing a specialized test that is called as dilute Russell Viper venom time test. Another test that would be done would be anticardiolipin antibody, for which we can be doing ELISA. And this ELISA it can be all 3 tests positive, then we'll say strongly positive. If 2 of them are positive, we'll say, okay, the test report is positive. Though any one of them is dangerous enough, but lupus anticoagulant, anticardiolipin antibody, or we can be doing ELISA for another one, that is beta-2 glycoprotein. Here, errors can occur because in MCQ, he can write words like microglobulin. So do remember that fact that what we are talking about in this particular case is beta-2 glycoprotein. You see, what he can do in the MCQ is he can introduce a small error, and that errors can result in, that error of judgment can occur in our mind. It is identical to what I was saying in the earlier part of the discussion. Remember, I was saying Maller rash, Maller flush. Closely matching words, no? Similarly here, beta-2 glycoprotein antibody is a high probability that one can actually miss that word. So the complete name is beta-2 glycoprotein 1 antibody, and that would again be determined on the basis of ELISA. And these laboratory based tests would help us confirm that, well, we are dealing with antiphospholipid antibody syndrome. The reason for pregnancy morbidity, as I've explained to you, is the placental infarction. We need at least 1 clinical criteria and 1 lab criteria. And for the lab criteria, it also says that these tests must be repeated at least 2 times, at least 12 weeks apart. Though some books might be mentioning 8 weeks apart, this is what Harrison says. So I'll just quote the textbook, that the testing for antibodies must be repeated at least 2 times. And if the test turns out to be positive on either of the 2 occasions, if it turns out on both the occasions, cool. But ideally, the testing should be done at least 2 times, 12 weeks apart, to be sure about the diagnosis. And we need 1 clinical criteria and 1 lab criteria for saying that this is antiphospholipid antibody syndrome. In case it's going to be associated with only this is occurring without SLE, then I will write primary antiphospholipid. If it is associated with SLE, then we'll say secondary antiphospholipid syndrome. The next image that you see is of that fishnet appearance that would be present on the legs of these patients, and this is referred to as livedo reticularis. These are dilated veins which are seen on the legs in a fishnet appearance. And there are multiple reasons why we can be having livedo reticularis. This can be seen as an isolated feature of SLE. It can be present in the topic of interest, antiphospholipid antibody syndrome. And the first time that we ever read this term livedo reticularis in our clinical career is most of the time with respect to polyarthritis nodosa, and then is with respect to a extrahepatic manifestation of hepatitis C, especially that's called as essential cryoglobulinemia. These are a couple of diseases where livedo reticularis is described. So SLE APS is routine, but that polyarthritis nodosa and cryoglobulinemia should also be remembered. Then a few words regarding the lupus anticoagulant antibody. In these patients, prothrombin time activated, partial thromboplastin time would be deranged. The clotting times will also be deranged. That's because I said the automatic load formation is occurring. And a specialized test for lupus anticoagulant that is asked is called as DRVVT. And this would be referred as dilute Russell Viper venom time test. I mean, first time when you write this name, no person would be scared saying Viper based test or a snake based test. So this dilute Russell Viper venom time test, how does it work? Well, the basic principle is that Russell Viper venom, it activates the clotting factor. I mean, the Viper you study in forensic medicine, the Russell Viper venom directly activates the factor 10 and it can result in a clot formation. But if there is an antibody present, then this antibody will prolong the process of this activation. So one, we will notice that because there is a presence of antibody, the serum will not clot. And then what we'll do is we will add rabbit brain phospholipids, and that will cause the shortening of the deranged clotting time, or the shortening of the deranged prothrombin time in these patients. So we need to demonstrate both the facts. One, that in a normal person, what happens is that addition of Russell Viper venom will activate factor 10 and will cause a clot formation. But in persons who are having antiphospholipid antibody syndrome, this clotting process will be hampered, and then we can ensure the clotting process by adding rabbit brain phospholipid from outside. And therefore this variation with the prolongation that is seen initially, and then you can shorten. By shortening, I don't mean that you are making it less than normal. By shortening, I mean you're bringing the clotting parameters back towards normal by addition of phospholipid from outside, is the essence of doing dilute Russell Viper venom time. And usually this would be like a one-liner MCQ. The DRVVT test is done to determine the presence of lupus anticoagulant antibody. And as I've explained, I mean, the name here anticoagulant is mainly to represent the in vitro activity of what it does. Ultimately, it results in clot formation. Ultimately, from the clinical perspective, it will result in all these bad prognosis that would be occurring. And now let's look at what are the therapeutic options that we'll be having. As I've explained, patients can be having false positive VDRL, that's mainly, or RPR test, that's mainly because of the cross reaction. Now, for management of these patients, if it is a first thrombotic event, what we'll be using is VKA. That is, most of the time, the molecule used would be warfarin, and the target INR in both the populations for venous thrombosis and arterial thrombosis will vary. If he says what will be your target international normalized ratio for a person who's had a venous thrombosis like DVT, and then possibly a pulmonary embolism event as well, though you did manage the pulmonary embolism on the basis of whether it is massive pulmonary embolism or not, but then these patients have to be put on warfarin on a lifelong basis so that we can prevent recurrence of that event. So we need to keep INR of double to triple of normal. But if it is going to be arterial thrombosis, if a patient can tolerate, we would like to go more aggressive and go to target INR of between 3 to 4. In contrast, if he specifically talks about obstetric antiphospholipid antibody syndrome, where we are having recurrent miscarriages, intrauterine death, or preterm baby delivered at 34 weeks because of eclampsia, then we will start the patient on LDA, that would stand for low dose aspirin. And along with low dose aspirin, the second molecule that would be used is low molecular weight heparin. Initially, we will be using low molecular weight heparin. I mean, the dosages would be on the lower side, and if required, if the recurrent miscarriage is continuing, then what we can do in this case is upgrade to therapeutic ranges and keep on prolonging the activated partial thromboplastin time. Even alternative approaches can be used. If like a combination of these two is not working, then we can be using additional immunomodulatory drugs as well. But he says that initial approach for obstetric antiphospholipid syndrome, that will be usually the question that would be asked to you, is low dose aspirin with low molecular weight heparin. And even if a lady with SLE with antiphospholipid syndrome, she's asymptomatic, she's never had any pregnancy morbidity at the moment, but her antibody tests are positive by high risk profile. By the meaning of the word high risk profile, I mean all these tests are positive in her. She's turning out to be having, I mean, lupus anticoagulant determined by dilute Russell Viper venom time test, kaolin clotting time, APTT, they're all deranged. ELISA for anti-cardiolipin antibody is positive, anti-beta 2 glycoprotein antibody is positive. If these tests are turning out to be positive, though she has not had an event at the moment, in future she can develop a MI or stroke, and that is why they recommend that these patients should be put on lifelong low dose aspirin. So these are the approaches that you need to remember, out of which the one that I mentioned for obstetric antiphospholipid is the most important one. So these are the details that I would like you to remember for this topic. And in the end, all I can say is that irrespective of wherever you are at this moment, whatever level of preparation, whichever college you are in, whether it's a tier 1 city or a tier 2 city, whether you are abroad as a foreign medical graduate, whether you're in a private college, I think, I mean, each of us has our own learning curve, and you just need to utilize time effectively. Because see, money can vary, fame can vary, your family background can vary. You might be very from a very rich family, you could be from an average middle class family, you might be on a loan. But one thing that is constant at this moment, what I can say is that time is one factor, guys, which will decide the ultimate, fate of yours a couple of months down the line. So if you're gonna utilize this time effectively by listening to the data that I'm saying, that data makes you much more wiser, data makes you much more mentally more aggressive, and by mental aggression I mean that you are in a position to solve MCQs much more better, and you are able to secure good ranks. So that's the main objective. So keep the pressure on, keep hammering, and you will break on to the other side.